And welcome to Unit 7. Can you believe it? This is our last unit. We're going to make it. And we're going to start off with urinary elimination. And then following that will be fluid and electrolytes, a little bit on perioperative care, and then finally values, ethics, and legalities. So a lot of interesting things as we wrap it up here. I think what you'll find interesting is once we do the urinary system, and the fluid and electrolytes, we will look at perioperative care, and perioperative care looks at all systems. So we'll get this nice review of all systems, kind of like when we started with the musculoskeletal system and mobility and how it affects all systems. And so we'll benefit by having that little bit of review here at the end as we prepare to wrap it up. So hang in there with me. We can do this. 3 more weeks. We can do this. So proud of you guys for sticking it out and listening to these videos and doing your thing. So without further ado, we will press on. So urinary elimination, you've already had some information on the flipped classroom. So what I would have done in class would have been, we already went over those on that other slide, was to see if you had any questions related to this content. Be sure and be familiar with how the kidneys work and these 5 functions, and make sure you realize them. I love this picture. It just gives you such a good picture of the nephron of the kidney and its function. If we were in our classroom, the working classroom, I would have had you work in groups, and one of you explain the picture on the left and one of you explain the picture on the right. Make sure you're familiar with the language. I already explained. I just love that hypotension, hypovolemia, renal hypofusion, renal ischemia, semantics to get us to this same outcome related to the renin-angiotensin system, so the RAS. All right, so just stop, take a pause, see if you can explain these pictures, if you really get it, and you can follow how that kidney is affected when there is not good enough pressure in the kidney to help it function. Got to have that filtration, which we'll talk more about with fluid and electrolytes. Be able to explain the urinary system, pretty straightforward. And that idea, I want you to make sure that you appreciate the detrusor muscle is the bladder muscle. And then when I don't know if the brain's the best terminology, but the nervous system function, that idea of voluntary and involuntary function of the urinary system. So also, I know I asked 1 or 2 questions related to what would be a cause of renal failure, and would you recognize whether that's pre, intra, or a post-renal condition that affects urination. And of course, you talked about all those things in the urinary system and a UTI. I have an activity for you related to urinary tract infections, diversions, and I want to pick up here related to urinary incontinence. I'm not going to repeat the words that were on the slide, but I did want to just emphasize there was one type of incontinence that I have on the list that was not in your book. That doesn't mean it doesn't exist. It means I didn't put it in the book, which is urge incontinence. And that's that, you can see in the picture, bladder oversensitivity from infection, often from, or could be caused from a neurologic disorder. And it's that urgency to go, like that commercial, gotta go right now. So urgency, and I don't really know why they skipped it in the book, but they did. I told you, an incontinence specialist come and speak at class for a number of years, and these were all of the types of incontinence that she treats as a nurse practitioner. And what wasn't on her list, which was in the book, is the transient incontinence and total incontinence. So I just want to make sure that we're all on the same page, and I realize they exist, you realize they exist. And as I was reading these 2 types of incontinence, the transient and total, it seemed to me like the transient was an acute type of incontinence. Obviously, it usually doesn't last more than 6 months. That was kind of key. So maybe something caused that, a medication, a trauma, a surgery, a condition, and then there's recovery from that type of incontinence. And then when it gets to the total incontinence, by definition, it's a continuous and unpredictable loss of urine resulting from surgery, trauma, or physical malformation. Urination can't be controlled because of an anatomical abnormality. And that would be the key and what differentiates that from total. So if you hop there to the middle, the idea of mixed is a combination of any of the types of incontinence that are there. So be sure and be able to recognize the definition or a patient's report of their symptoms, and would you be able to label that type of incontinence for the client. All right, so we're going to pick up here with some new information and start with looking at infection control and hygiene issues related to urination. We can't neglect toileting as part of that process. As humans, we were meant to be upright to fully empty the bladder. So if we don't empty the bladder completely, then that can put the client at risk for infection. So assessing the client's ability to get to the toilet and then measuring volumes to see if they're emptying their bladder completely are important. If a client can't get to the bathroom, then a bedside commode or commode chair might be necessary to help facilitate that uprightness. Some people honestly cannot use other means like bedpans and urinals to go, whether that's that voluntary piece, you know, the brain is on it going, this isn't how I go, or what the deal is. But as much as we can, we want to provide the most normal standing, sitting scenario that we can. Bedpans and urinals are a wonderful alternative when people are on bed rest for whatever reason, whether it's, you know, a medical, physical condition or what is going on with people. So just know that those exist and that are there. When someone is using a bedpan, as much as possible, sit them up so that they're in as much of a sitting position as possible. And same with urinals. If people, mostly men, they do have a female urinal, and those can be helpful. So getting people sitting up will help, because we're wanting to empty the bladder as much and as normal as possible. When it comes to infection control and hygiene, skincare is really key. People need to be cleaned well, because there can be causes of problems related to incontinence. On the next slide, I think I talk about what happens when someone has breakdown of the skin. So infection associated, what's that word be? I can't remember, all of a sudden my mind went blank, but it'll come to me in a second. We want to protect their skin. So making sure that people are getting clean, that we're getting the urine off their skin, of course, if there's stool, feces off their skin, because that can cause breakdown. And there you go, breakdown. Skin barriers can be very effective. You know that when babies get rashes and their skin could potentially break down, that we put A&D or Desitin barrier creams on them to keep the urine, that uric acid, the ammonia off of the skin, because it can be so irritating. The same is true for adults, and there are a lot of different products out there that are available as a skin barrier. We've used the skin barriers on our skin when we were in the skills lab. Those will work, but so can something as simple as Vaseline. I've even heard skin care nurses say Crisco, if you're in a desperate situation, is something that will keep that off of skin, the urine, and keep that skin protected. The other thing is, if people are struggling with or challenged by incontinence and leakage of urine, then having a good understanding of absorbent products that are available is important. Panty liners. Maybe there's just little leakage sometimes of coughing, sneezing, and such, the stress incontinence. And so maybe it's a simple product. They have underwear now that it has barrier in it for clients, so it doesn't look bulky. People don't want to be wearing diapers, and we don't use that word on adults, right? There's some kind of a brief or an absorbent barrier product. So yeah, familiarizing yourself with what's available, what the client uses, and the accessibility of those products. If people are incontinent and leaking urine, the product needs to be absorbent enough so that it wicks away the urine so it's not on skin. But then there's also the idea of odor. People don't want to smell like urine and have that going on. So the frequency of changing of products in general, cleanliness and hygiene. So very important for management of clients, which leads us to the idea of educating our clients as to correct hygiene. We talked about with infection, wiping front to back, cleaning the meatus and back, and the right amount of fluids, the types of foods that people can eat to prevent infection. Are important. I loved in your book, there was a page, and I should have written down the page number. Let me look here. I have the book sitting right in front of me. It talked about how to care for, here we go, I think. Yeah, focus on the older adult and how to care for clients that have nocturia, incontinence, and urinary tract infections. And that's on page 1358. That's a great way to start working with your clients. And then on page 1368 and 69 were a lot of steps, not only for nursing, but for clients that would have urinary catheters and how to care for those. We'll talk more about catheters when we get there, but they need to know that you don't just have a catheter and that's it. You don't have to ever clean around the genitalia area. You do. And so not using soapy products, not taking baths, but showers and such when there's catheters and going on. When people have had a catheter, I just want to reemphasize, we've talked about this before, but that CAUTI and our prevention of catheter-associated urinary tract infections, which means not only good peri-care and encouraging fluids and cranberry juice and such, but it also means getting that catheter out as soon as possible. I know at the hospital where we normally would have clinical, they keep a board up that has which patients have catheters, how long they've been in, and every morning when they do their huddle, they get together each shift during that shift and say, can this catheter come out? How long's it been in? Has the doctor been notified and reminded about this catheter, so that we can get them out to help prevent urinary tract infections? Very important. And it's being tracked, and it's not just being tracked by us because we're going to be great, wonderful practitioners, right? But they keep data on that in the hospitals as to how many urinary tract infections if a client came with it, or if they were readmitted for that after they were hospitalized, or if they got a urinary tract infection after catheter and such, and that data is tracked throughout the hospital. So we want to know what's going on with that client and take good care of them. So they're clean. You have to clean around the meatus with just plain water. Don't want soapy, perfumey, or lotiony type soaps in the perineal area. It's not necessary to clean with chlorhexidine or iodine around the catheter. They used to do that. We've done so many things over the years. We don't do that anymore. But making sure it's cleaned with water twice a day is usually the normal practice. And one of the things I've noticed with catheters when I'm doing catheter care is that sometimes there can be a little buildup of crusty on the catheter, and you need to get that off because it's a perfect reservoir for microorganisms. And for the female, that's just a short trip to the bladder. And so we want to take note of that. All right, it is important that we realize that there's differences related to urinating through our developmental years. And I just find it interesting, just some fun facts for you. Adults, when it comes to their kidneys, do not reach their maximum size, wait for it, till between 35 and 40 years old. So some of you still, you got your baby kidneys coming. At 50, they start shrinking. And by 80 years old, 30% of the nephrons are lost. So we're kind of at a maturity when it comes to kidneys around 40. And then at that next 40 years, about 30% loss of kidney function. So there's a progression. Infants have very immature kidneys, and they're not able to concentrate urine until about 3 months old. So their kidneys just aren't as efficient. And as you know, they don't have control over their bladder. And so they're incontinent for a number of years. They produce a high amount of urine comparatively to adults because of their high metabolism. But they're just not as efficient. Toddlers and young children then begin to have better efficiency, their urine starts concentrating after about 3 months, starts getting to be yellower. But after about 2 years, then toddlers can sense bladder fullness and are able to hold their urine for a reasonable amount of time, for a couple hours, an hour or two. And so really for toddlers, they don't need to be pushed into being potty trained until somewhere around 2 or 3 years of age. They have to be able to sense that their bladder is full, or that there's urine in there. And like I said, they should be able to hold it for 1 to 2 hours. When it comes to potty training toddlers, daytime continence precedes nighttime control. So you'll be able to work with kids during the day, but they still may wet the bed for a while. So that's why, you know, putting your pads on, or they might have their pull-ups, you know, or briefs for during the night until they're able to hold it through the nighttime. Let's see, adults, kind of gave you some scoop on them. Adults should be able to hold their urine for a minimum of 2 hours. That's fairly normal. And longer. In your book, it talked about sometimes going 8 to 12 hours. And I'm like, a nurse wrote this book, that's for sure, because there were days I didn't go to the bathroom when I was working. And part of it has to do with fluids in. So fluids in, fluids out. If you're drinking a lot during the day, then you're going to have to go more regularly. If you're not, if you're dehydrating yourself, then you're not going to have to go as often. But adults need to go to the bathroom every 2 to 3 hours, because if you don't, then that makes the adult more prone to urinary tract infections. So we do have better control, obviously, but because of our ability to control, we can get ourselves into trouble as well. There's a lot of things that affect the frequency with which adults go to the bathroom. And a lot has to do with how toileting availability, fluids in, but medications may affect urination and cause some retention, or may cause frequency if people are on diuretics and such. So medications, aging, the neurosystem. Sometimes people think every time they feel like they need to go, and so they train their bladders to go more frequently. There's a lot of things that affect urination and the training of our bladders. And we're going to talk about some things that can help with that. Older adults can run into some problems. We've already talked about the loss of nephrons, but muscle tone, so related to incontinence, so losing some of that tone, maybe some increased urgency. For male clients, they might have an enlarged prostate, and prostate enlargement, it begins typically for the male around 40 years old, and so that can affect two things, which would be urinary frequency, going a lot, that overflow urine because the bladder gets tipped, and even some retention. There's changes in the kidney and the bladder with aging. Elderly often complain of urgency and frequency related to aging. And so one of the things that happens because of normal aging and then the possibility of a urinary tract infection is that if older clients are going to the bathroom more often, they think it's because they're older and maybe don't recognize that they have a urinary tract infection. Their temperature may not go up, and so they don't have that benefit. And there you go. So they tend to, elderly clients, and what's elderly these days, but most of the time we're talking over 65. So clients that are over 65, 70 would present with confusion before they would recognize their urgency or frequency, or maybe not even feel the burning. So confusion is a common symptom of UTI for an adult client. So that gets kind of tricky, that confusion thing, because if a client's a diabetic and a client has COPD and a client is older and is at risk for UTI, and there's a couple other things, but all of those, like an elevated blood glucose can cause somebody to have some confusion, and hypoglycemia can cause some confusion, right? So, okay, that's tricky. If your oxygen level gets too low, that can cause some confusion, right? The hypoxemia, we talked about that, as does urinary tract. So, I mean, you have to kind of think Maslow's here. What does this client have going for him? Is this an oxygen thing? Is this a diabetic thing? Is this a urinary tract thing? So a diabetic would be more prone to a urinary tract infection because of elevated blood sugars. Okay, so just because I just wanted to complicate your life. It's not just about memorizing some rules. So, oh, they're confused. They must have a UTI. No, but it does need to be ruled out. So that's part of the package of that. So just know that we're different as we go through the aging process. Some psychosocial considerations when it comes to urination can be self-concept. And when we think of self-concept, is kind of like, are you comfortable enough to excuse yourself to go to the bathroom, or comfortable enough to go where someone might be able to hear you going, that kind of thing. So self-concept, and it could be also related to even cognitive impairment, that ability to know or not know that they need to go to the bathroom. Culture may play a part in when people are able to relieve themselves and when they're not able to. And for gender, females tend to get UTIs more often than men, and males get infections, urinary tract infections. They still can get them, but it's more related to renal disease than it is the migration of a microorganism up their urinary tract. However, if a male has a urinary catheter, then they too are at risk for inadvertent contamination related to urinary tract. So all of that, if we go back then to the psychosocial considerations, how do they feel about their body urination? How do they feel about protecting themselves from a urinary tract infection? We talked about in the flipped classroom, after intercourse, that you should get up and go to the bathroom. Do people feel comfortable enough to do that? I was reading, I think it was in this book, that to drink 2 glasses of water or something before intercourse and then 2 after, and I'm like, oh my goodness, all this work for something that's supposed to be amorous. So self-concept, comfortableness, culture, the gender needs and such. So there's a lot that goes into play here. Again, that kind of adds to that voluntary, involuntary component related to urination. All right, so we've done a lot of pathophys related to elimination. Let's get some history related to elimination. So you want to talk to people about their patterns of urination. So here's some terminology that could be helpful related to patterns and frequency. We need to be sure and understand what anuria is, and according to your textbook, it is less than 50 milliliters of urine per day. That is like barely going, and we need to go because we need to clear out the waste products. So keep staying alert to that, what they say, that quantity sufficient. You'll see that term used in charting sometimes. And so anuria is not sufficient to excrete the waste products. Oliguria can border on sufficiency, but oliguria, according to your text, and I'm going to clarify why I'm emphasizing that according to your text, but oliguria is less than 400 milliliters a day and greater than, obviously, this 50 milliliters, sorry. So I'm struggling a little with this. Your book's a little bit different than what I've used before, not significantly. Anuria, I've always used the definition to be 100 milliliters or less, and oliguria was 100 to 500 milliliters. So I thought it was interesting that your book went 50 and 400. That's not a significant difference, and so if they're less than 100, they're getting into trouble, and that we would want to know. Same as if it's less than 500, now we need to distinguish between the two. Anuria is, can be related to kidney failure. Your your renal failure clients that are on dialysis, they don't produce urine if the kidneys aren't working. That's why they're having to do dialysis. And so taking note of that. Polyuria, interestingly, your book didn't really give you much definition on that other than it was excessive urine. So it would be over 2,000, 2,400 milliliters, whatever that client, exceeding their intake, if you will. Retention of urine, we talked about that. Can be that dribbling kind of a pattern related to incontinence. So maybe they aren't emptying their bladder well, which gives us this terminology that we want to keep up with too, which is that post-void residual. Back in the day, when we wanted to know what that value was, a client would void, and if there was concern that they were not emptying the bladder, then the doctor would write an order for an in and out or a straight cath, which is a catheter that doesn't have the balloon in it, and it just goes up and it drains into this bag that's attached, and you see how much is left in the bladder after they voided. Well, it's a new day, and we'll see some tools that are available to us, but this post-void residual, we can measure that through ultrasound as well now, and they're on the units, the floors where I work, and so those are available to us. That's non-invasive, so it decreases the risk of urinary tract infection, and it can measure the volume of urine that is left after voiding. So what is normal? Again, we'll go with your book, and this is pretty standard measure, and the book said 50 milliliters of urine left to nothing, that would be normal. And then if it exceeds 100, that's abnormal. So I've always, again, worked with that kind of 100 mark. And so if it's more than 100, then they usually do something about it. And if it's less than 100, then they don't usually have an intervention involved. So that's your barrier mark there for that residual. And then, do people have complaints related to their alterations in urination? So they complain about, you know, oh, I should have taken stock out and panty liners because I'm using them all the time. Or, oh, every time I cough or sneeze, I, you know, wet my pants. Those kinds of things. Dribbling. I can't get my stream going. That you would hear that from a male more often related to prostate. So what are they reporting? And are you asking the right questions to get that information is really key. There's factors that affect urination. I mean, we could talk circadian rhythms, diet, meds we've mentioned, and the amount of fluid that people take in or don't take in can all affect urination. So taking note of that. When we do, then we've got some history for our assessment. It's still all assessment. Then you want to also do a physical assessment. And yep, that means getting down there and looking at the perineum. And honestly, I don't look at every single person's perineum, but I do most. We just need to know and note if there's any rashes on the skin, any redness, any breakdown. Everybody gets looked at when they're hospitalized. First day they get a skin assessment with 2 people because we want to make sure that people didn't come with something that they claim at the end of hospitalization they didn't have. So we want a good baseline. On a day-to-day basis, you know, any changes? Do you have any rashes, any burning, anything like that? So when we got to this, the IAD, I remember the first time I saw that up on a board, I went, what is that? So incontinence associated, what's the D? See, I lost it again all of a sudden. Oh, I hate that. It's going to come to me at a relaxed moment here in a second. It has to do with a rash, skin breakdown, right? So what's going on with them there? Their kidneys, the I and O, we want to look at kidney issues. When I'm thinking about kidneys and I'm doing an assessment there, kidneys will have pain at a certain area of the body. So if someone is having kidney pain, they'll report a dull, aching, steady pain at the the flank areas, right? So kind of below this the costovertebral angle, that's right here. We've gone over that here, and it's here in the flanks or in the back by the ribs. They will complain of that pain posteriorly in the flank area. If they complain of urethral pain, they will complain of it being here in the front at the costovertebral angle. So at the dull aching in the back and the flanks, they can also have it some in the front for kidneys, but the ureters will be lower here on the front below the costovertebral angle. Bladder pain will be over the symphysis pubis area, and urethral pain, right? Ureteral and urethral pain is pressure or burning with urination. more around the perineal area. So where people complain of pain will help you better understand where infection or injury is. Now, I have a video for you. It's about 5 minutes, and it is how urine is made. So I think it just puts it together for you very nicely, and I just want you to watch it. You don't even really need to take notes. They talk fast. But I just want you to see the physiology of urine, all right, making urine.
The renal system consists of the kidneys, connecting arteries and veins, and the urinary tract. The kidneys are paired, bean-shaped organs lying outside the peritoneal cavity in the back of the upper abdomen, one on each side of the vertebral column. The kidneys function as the body's main excretory organs, eliminating the body's metabolic waste products by filtering the blood. Substances that are unneeded or are present in excess are filtered out of the blood and form into urine, moving via the ureter into the bladder before being expelled through the urethra. The kidneys also selectively reabsorb those substances that are needed to maintain the normal composition of the blood. By adjusting blood composition, the kidneys are able to maintain blood volume and pressure, ensure the proper balance of sodium, chloride, potassium, calcium, hydrogen, phosphate, and pH, and eliminate products of metabolism such as urea, uric acid, and creatinine. The medial border of the kidney is indented by a deep fissure called the hilus, where the blood vessels, nerves, and ureters connect to the kidney. The kidney is composed of up to 18 lobes. Each lobe is composed of nephrons. Nephrons are the functional units of the kidney, and each kidney contains more than 1 million nephrons. Each nephron consists of a glomerulus and a system of tubules. The glomerulus is a unique, high-pressure mass of capillaries that filters the blood. The glomerulus is encased in a thin, double-walled capsule called Bowman's capsule. The space inside the capsule and surrounding the glomerulus is called Bowman's space. Plasma-like fluid is filtered from the capillary blood into Bowman's space through the glomerular filtration membrane. The glomerular filtration membrane consists of 3 layers of capillary wall: the endothelium, the basement membrane, and the epithelium. This membrane allows some particles from the blood to pass through, but not all. The fluid that is filtered from the capillary blood into the Bowman's space is called filtrate and forms the primary urine. The filtrate then diffuses across Bowman's space and into the tubule system of the nephron. In the tubules, some substances are added to the filtrate as part of the urine formation, and some substances are reabsorbed out of the filtrate and back into the blood. The nephron tubule is divided into 4 segments. The filtrate passes through each of these segments before reaching the ureter. A highly coiled segment called the proximal convoluted tubule, which drains Bowman's capsule and where almost complete absorption of nutritionally important substances takes place. A thin looped structure called the loop of Henle, which reabsorbs water and ions from the urine and plays a role in controlling the concentration of urine. A distal coiled portion called the distal convoluted tubule, which regulates potassium, sodium, and pH, and where further dilution of the urine takes place. And the collecting tubule, which joins with several tubules to collect the filtrate and where final sodium regulation takes place. Each kidney is supplied with blood by a single renal artery that arises on its respective side of the aorta, before dividing into 5 segmental arteries that enter the hilus. Within the kidney, each segmental artery branches into several lobular arteries. The lobular arteries further subdivide to form interlobular arteries, which branch off into afferent arterioles. Blood flows into the glomeruli through the afferent arterioles. Blood flows out of the glomerulus through the efferent arteriole. The afferent and efferent arterioles regulate glomerular capillary pressure by selectively dilating or constricting. The kidney's venous blood, now filtered, flows from the glomerulus via the efferent arterioles into the peritubular capillary network, a low-pressure, reabsorptive system surrounding all portions of the tubules. This arrangement permits rapid movement of solutes and water between the fluid in the tubular lumen and the blood in the capillaries. The peritubular capillaries rejoin to form the venous channels by which blood leaves the kidneys and empties into the inferior vena cava. Urine formation involves the filtration of the blood by the glomerulus to form an ultrafiltrate of urine, the tubular reabsorption of electrolytes and nutrients needed to maintain the constancy of the internal environment, and the secretion of waste materials. Filtration occurs as blood flows into the glomerulus from its afferent arteriole, and plasma moves through the glomerular capillaries into Bowman's space. From Bowman's space, the glomerular filtrate moves into the tubular segments of the nephron. Here, through tubular reabsorption, electrolytes and nutrients move from the filtrate back into the bloodstream. Here also, through tubular secretion, substances move from the peritubular capillaries into the urine filtrate. The filtrate concentrates in the collecting tubules, then finds its way to the renal pelvis, where it is directed to the ureter, the bladder, and the urethra for elimination. The kidneys perform an excretory function by filtering the blood and then selectively reabsorbing those materials that are needed to maintain a stable internal environment. The nephron is the functional unit of the kidney and is composed of a glomerulus, which filters the blood, and a tubular component, where necessary substances are reabsorbed into the bloodstream and unneeded materials are secreted into the tubular filtrate for elimination in urine.
I hope you love that. My favorite part is the filtration at the end, where it goes in and then it secretes out. Because don't you just wonder how that all goes back and forth? Yeah. We're going to talk more about that with fluid and electrolytes, but I think that's just a great visual for us. So, physical assessment, understanding how the kidneys, bladder work, how urine's made, and then assessing them. The bladder, just by way of physical assessment, is not palpable when it's empty, because it's recessed down there below the symphysis pubis, but as the bladder fills, it comes up and above. Now, a word that your book didn't use that I think is really key is that for us to palpate the bladder, you have to do a deep palpation, and we're not doing deep palpations in first semester. So a deep palpation takes your hand sideways like this and goes into the stomach to feel where the bladder is. And you need to ask your clients or explain what you're going to do. When I've gone to feel for bladders, I've started the umbilicus area to see where I can feel it, and you can feel the top of it if it's really full. And so we would explain that the bladder is palpable at the umbilicus or 2 finger breadths below the umbilicus or such, so that when the doctor is contacted, you can say what you palpated. Can I do a straight cath, or do you want a urinary catheter for this client? An ultrasound to see how much urine is in that bladder. Bladders typically want to be emptied somewhere between 200 and 400 milliliters of urine. That's the normal bladder, fills up like that. But that bladder, I've seen clients, I've put catheters in and taken out over 1,000 milliliters of urine. They had to be miserable. So just knowing that that exists. All right, and by way of definition during that video, I had to look it up because my brain was just not letting it go. Incontinence-associated dermatitis, which is a big word for a rash or breakdown related to urinary incontinence. All right, so we're assessing our client, and other things that we would assess would be I&O. You're familiar with that. You're familiar with color, clarity, and odor, but I did want to stop for just a brief second and talk about medications that can change the color of urine. I mean, we've been talking about all these different ways that are looking at urine, maybe assuming that it gets dark amber because they're dehydrated, or it gets pale yellow because they've had a lot of fluids. But there are other changes, and on page 1347, this is a great list. I just had one other color that I think they didn't handle or didn't add here, but if someone's on blood thinners, you always want to be alert to seeing if their urine is pink tinged or red, because they can have blood in their urine. Diuretics, if they're getting rid of a lot of fluids, then that'll make for paler urine. Pyridium, which is the trade name for phenazopyridine, the urinary tract analgesic, which that's a beautiful thing if you've had a urinary tract infection and you've got that frequency and urgency to go, and that pyridine is analgesia for the urethra, and it turns urine orange, orange, orange. So that's worth noting. Antidepressants can turn the urine, especially the amitriptyline, can turn urine green or blue-green. And then B complex, they said, could do green or blue-green. But I tell you, I just have to share this, maybe too personal, but I take a super B complex vitamin every day, and it makes my urine bright yellow. So there's no green there. So some vitamin complexes can change, but bright yellow. So that would be the change I saw from the book. And then L-Dopa meds, anti-Parkinson drugs meds can turn the urine brown or black. Ooh, can you imagine having black urine? That would be disturbing. All right, so color. It's more than just, oh, it's light yellow, it's dark yellow. No, it's green, or it's, you know, something else. So take note of that. And then collecting specimens. We did much of that in the lab, skills lab. We talked about how to get urine from a Foley catheter. You know how to do a midstream. If it's just a plain urinalysis, then it doesn't have to be sterile. But if it's a midstream, then it has to be a sterile cup collection. So you need to know what the urine is being tested for. If the client, you're suspicious of a urinary tract infection, then that's going to be a midstream. It needs to be kept as sterile as possible because it needs to be cultured, the culture and sensitivity of that urine. So know what you're testing for. There are other urine tests, the 24-hour collection. I think I mentioned it in my groups. I don't know if all the groups talked about a 24-hour collection. And often that's to check for creatinine levels. We'll get to that at the next slide when we talk about labs. But when we do a 24-hour collection, you need to make sure that the client voids at whatever time, let's say 10 in the morning, they void, and that urine is discarded. That one's not counted in the 24 hours. Then everything is collected until 10 o'clock the next day. So at 10 o'clock the next day, you ask the client if they can go to the bathroom. They do, or they don't, whatever, at 10 o'clock. And then that urine is added to the collection and it's over. So there needs to be good signage in the room so that people don't dump urines, and make sure clients don't put toilet paper in urines. You try to separate stool from urine, keep things separate. And depending on what they're collecting for, you need to double check whether menses is a problem, because if blood contamination would change whatever they're looking for. So the lab is a wonderful place to call and get some clarity on that. And there's always policy and procedure manuals, lab manuals, to let you know what you need to do. Some specimens have chemicals, preservatives while you're collecting. Others have to be on ice or be refrigerated, and you need to know that so that you don't go to all that work and then you didn't do it right and they're out of luck and have to do it again. Sometimes people forget and they'll dump a specimen in the middle of the 24 hours or such, and so you usually have to start over at that point, which is a bummer for everybody. So make sure everyone is informed. That's where signage is helpful, and making sure the client knows. So like when the staff go to lunch or something, the people that are covering don't mess it all up. All right, communication, very important. Lab analysis is another important piece of our assessing of the urinary system. And so some important labs you probably are familiar with. We've talked a little bit about them, but we would look at the creatinine level. The importance of creatinine when it comes to urine is that we need to know that creatinine is a byproduct of the skeletal muscle contraction. And the kidney is the only organ that excretes creatinine. So when we're measuring the creatinine in the urine, and I'm kind of double dipping into our fluid and electrolytes chapter, but it's important enough that we've got to understand this, and that is it's a direct proportional measure to the glomerular filtration rate. So as much creatinine is excreted tells you how well the glomerulus is functioning. Makes sense, right? So a glomerular filtration rate should be around 125 milliliters per minute. If that is so, then the creatinine level will be 125. Do you see? They're the same. So, creatinine clearance decreases 6.5 milliliters per decade of life after 20 years old. Huh. Right? Very interesting. So, now, if we're measuring urine creatinine, the creatinine should be in the urine. Well, if we draw blood and we're checking the creatinine level should be low, very low. It's never going to be zero because it's got to go through the blood to be excreted through the kidney, but it should be low. So a normal serum creatinine is, again, these are maybe a tenth off at different labs, but 0.5 to 1.5 milligrams per dilution. All right, and that should be constant. So if the serum creatinine gets elevated, then there's some renal failure, and the degree of failure and repair is what's going to be monitored. So that's the significance of this creatinine level. It's giving us some insight into kidney function, as does the BUN blood urea nitrogen level. It shouldn't be high in the blood of a client, the BUN. It should be excreted, the nitrogen products. Potassium, the pH, bicarb, all of those will give us some idea of how the kidneys are functioning. And these are blood measures. The H&H value, the hemoglobin and hematocrit, help us understand how well this kidney is functioning. Okay, so those are blood values. Common urine tests, your basic urine analysis, and it could be, again, the urine, how it's obtained, whether it's a midstream or not for culture and sensitivity. Specific gravity is the measure of solute, so how concentrated the urine is. Your book's values for specific gravity are a little different, again, than what I normally have used as a value. So for the creatinine, for the specific gravity, I use the value of 1.01 to 1.03, and that works for me. So know this, water is 1, the amount of solutes in water. So the closer the number is to 1, the more dilute it is. The higher the number, so when it starts getting over that 0.3, right, 0.3, it's getting more and more concentrated. So that can be an indication of dehydration. Okay, specific gravity, the amount of solute in urine. And culture I already mentioned. So some lab values, and I just copied these lab values, how it might be reported in a chart. So in this particular one, when you're looking at lab, the color was yellow. It was clear that's what it's supposed to be. Specific gravity is high, right? 1.023. Oh, well, it's not over 3. And normal is 0.3. So that's within normal. pH, normal is 5 to 8. And again, that can vary just a little depending on who you're reading. But this looks like to be normal, although they've got sugar in their urine, they're spilling sugar, right? All of these should be negative. There's some trace of blood, maybe some irritation. So the bilirubin is normal. Red blood cells looks normal. There's maybe a little in there that they picked up. So that's what you're looking at. So in this one, it's just, they're spilling urine. This is a client that you'd want to double check that to their blood glucose. All right, diagnostic tests. I'm not going to go into depth with them because really we just don't have to know them that well, but I want to emphasize a couple of these. The KUB was not mentioned in your book, and I thought that was interesting. That's a simple X-ray, kidneys, ureter, and bladder. And maybe in this particular sense, they would be looking for kidney stones or just kind of a general look. There's no prep for that. It's non-invasive. They just take an X-ray. Whereas some of these other exams, you want to be aware of which need consents, what kind of prep there is, so pre and post procedures, and if there's any allergies specifically to the contrast medium. So to iodine, and therefore we would ask, do you have trouble with shellfish? Because that's the base of those products. So when you're looking over these, and your book was wonderful about listing all of these and telling you what it's for, what kind of prep there is, and what nursing interventions you would want to be aware of. Just know that all that exists on the hospital floors so that you could check that out. What you would want to know is which of these might use contrast and which of these are invasive versus non-invasive. So pretty straightforwardly, I'll just give you the non-invasives. The KUB, non-invasive, it's an X-ray. The renal ultrasound, and that's different than what we have here as a bladder ultrasound, bladder scanner. I put that on the picture. That would be non-invasive, and a CT scan can be non-invasive unless they use contrast, and then they would have to put an IV in to give the contrast. Sometimes you can drink the contrast, so it just varies how they're going to handle that. So you just want to be sure. The cystoscopy is under some kind of sedation. It's because they have to put a tube up, like a urinary catheter, to go up and look at bladder, ureters, and such. The intravenous pyelogram is invasive, as is the retrograde pyelogram. So just kind of having a sense of what's invasive, what's not invasive, what kind of consent would you need, and such. So just, you don't have to memorize every iota of all these tests, but have a general idea of what's available out there. As far as testing goes. And I think I didn't even list, there was one other test that she put in her list, Taylor, the author, having to do with or urodynamic studies. I didn't even add that as well, but measuring urine outflows and of lower urinary tract function. So there's, no wonder we have specialists, right? Urologists, they have a lot to figure out. All right, so we've done all this assessment. We've gathered all this data to help better understand the client, and note that there are a bunch of nursing diagnoses for us. And I love that one of them is urge incontinence, even though it wasn't in the book. So that just re-emphasizes what I had to say about that. So you can get a definition about that if you go to your care plan book. So a number of definitions, or a number of nursing diagnoses, because that's their response to whatever condition they have. Some goals and outcome statements we might write is, client will void more than 200 milliliters within 8 hours after catheter removal. Very measurable, very specific, got a time frame. So that's a nice one. Client's bladder is not distended on palpation throughout hospital stay. A little more generic, because the bladder will fill, but we don't want it to, maybe be even more specific, you know, never above the 2 finger breadths above the symphysis pubis or something. So that could be something that we could write. If a client, you don't want them to have a infection, maybe they have a urinary catheter, and the outcome statement will be no signs and symptoms of infection. Don't just write that. Say what you mean by signs and symptoms. Fever, pain, blood in urine, burning with urination throughout hospital stay would make sense. So then we're going to implement things to help care for our clients. And we've talked about a lot of these, so some I'll breeze through pretty quickly, but we want to educate our client about the appropriate fluid intake. And we want to encourage the average adult, and don't make up a story, but 8 to 10 8-ounce cups a day of water or liquid. It should be 2,000 to 2,400 milliliters kind of a thing. We keep those kidneys flushed. We want to find ways to promote normal voiding, micturition, by stimulating the reflex to go or training us not to go. I had a girlfriend recently that said she was having trouble with urgency, and so she went to the doctor and said, I feel like I should go every hour, and the doctor said, well, you don't, so don't go. Just try training your brain not to go. And she said, it's the craziest thing. If I just tell myself no, I don't go. So just some training that needs to happen. Maintenance of habits and fluid intake. Maybe if there's enuresis, not drinking a couple hours before bedtime so that people aren't up and such. Promoting complete bladder emptying, which may have to do with timing, positioning, and being able to completely empty that bladder. Preventing infection through hygiene, acidifying urine, we already talked about that. And promoting continence through Kegels or the pelvic floor muscle training, which I have another slide for. But I noticed on your book that it talked about avoiding caffeine. It didn't say spicy foods. I added that. Artificial sweeteners, because they can affect continence. And so why is that? Well, caffeine is a diuretic, and so that can cause people to have more frequency. Spicy foods can be irritating not only to the stomach, but they found that it can irritate the bladder. So maybe avoiding spicy foods can help people that are having issues with incontinence. And then artificial sweeteners, I'm like, what's with that? And the deal with artificial sweeteners is they are a bladder irritant. So maybe an option would be honey over an artificial sweetener when people need some sweetening. So just some ideas of things to help promote continence. We want to maintain people's urinary elimination habits as much as possible. So safety, night lights, things like that, helping them go when they need to go. I talked earlier about catheterizations, the suprapubic catheters in the flip classroom. I don't think I talked about the condom catheters. Now I can't remember. But knowing that that's an alternative, we did share those, the techniques and how to care for those in the skills lab. So making sure that we're checking them. As far as story goes, I just have to get this one out here. For a season when I was a home care nurse, done a little everything over the years, there was a patient that was a quadriplegic. So consequently, he didn't have bladder control. And so he would have a urinary catheter for a while, and then he would get a urinary tract infection. So they'd have to take the catheter out, and then he would have a condom catheter. But the condom catheter caused irritation around the shaft of his penis, and he would get skin breakdown on his penis. And so now he needs a urinary catheter. He was a young guy. He was not interested in briefs and all of that kind of thing. So for him, it was a vicious cycle. Why do I tell that story? You got to check under those condom catheters and look at the skin and make sure that it's not irritated. Medications. Oh, I talked about medications can cause the urine to change color. Some can, but medications can affect urination. One of the things we maybe don't think about is that blood pressure meds cause muscles to relax so that the blood pressure won't be so high, so the vessels relax. They have a muscle relaxant quality to them. Well, the bladder is a muscle. And so sometimes a side effect, and people might say adverse, is they're getting incontinence because of the med they're on. Muscle relaxers can cause incontinence, or they can cause retention. Sometimes people that are on pain meds, then they can't go. So it gets tricky. And then we're trying to, as we said, avoid urethral catheterization as much as possible. I like this picture because I just wanted you to see where that catheter goes. The holes are here, so the urine goes out the holes, and then the bladder keeps it from falling out. This catheter over here is a leg bag. So people want to go out in public and go grocery shopping, and they have a urinary catheter, but they don't want it hanging on their wheelchair or whatever. And so a leg bag might be most appropriate. The bags need to be emptied. Leg bags need to be emptied when they're at half and no more than 2/3 full, because they can just get too full and leak and get some backflow possibly. So take note of that. As far as types of catheterizations, I don't need to go into a lot of that. You're going to do a lot more with catheters second semester, but there's straight caths, there's retention or urinary drainage, the Foley catheter. There's double lumen and triple lumen catheters, and that's what I really wanted to mention, which has to do with irrigation. So the picture I have right here is a catheter type. It's a triple lumen catheter, and it's meant for somebody who needs to have their bladder irrigated continuously. CBI, continuous bladder irrigation. And so here's the irrigation bag. I went over this in Skills Lab. It's set up, and so the irrigant comes in, rinses the bladder, and then just by gravity comes out into the drainage bag. And I gave you that little example of, this looks like a 1,000 milliliter bag. So let's say they have this 1,000 milliliter bag. I showed you a 3,000 milliliter bag. And in fact, I think I showed the Monday group, but I didn't show the Friday group because somebody pulled the spike out of the bag and it all leaked out and we didn't have a bag. So anyways, so you Friday people, take note. If there's 1,000 milliliters in here and all 1,000 went in the shift, okay, so you're doing your I&O. You know that you would be having to empty this drainage bag 2 or 3 times, right? Because it can't handle 1,000 milliliters. You've seen what a urine bag looks like, plus urine? No. So, okay, so you've emptied it, and at the end of the shift, you realize that 1,000 milliliters of irrigation went in. Okay, that's the CBI, irrigation. And what came out was 1,800 milliliters total. So if 1,000 of irrigate went in, but 1,800 came out, how much is urine? Well, 1,800 minus 1,000, you get it, 800. And that's how we figure out I&O, because we still want to keep track of, is urine coming out and is it getting blocked? All right. And then you guys did removal of catheters, and so you want to, again, use aseptic technique. You want to pull that out with gloves and such, and then good pericare after, and then keep track of when their next void is. Sometimes they even have us measure the volume of the next 3 voids to make sure they're going greater than 200 milliliters per void, because sometimes if they've had a catheter in for a while, they may only go a little bit, or they may have urgency or something, so we want to make sure and check that. All right, some other things that we can do. We've talked about these the pelvic floor muscle training, or the Kegels. We want to strengthen that pelvic floor. So a couple things that aren't in your book is the name of that pelvic floor muscle, and it's actually called the levator ani. And so the levator ani is this muscle here, the pelvic floor, and it weakens because the urethra, oops, I didn't mean to go that far. The urethra, well, there's your answer. The urethra goes through it, and so that can weaken this muscle. And so we want to strengthen that and tighten it up. Now, if you guys were in class, I would make you all stand up and do this exercise to do your pelvic floor exercise. It's not just squeezing, because that's not enough. And so what you want to do, and you can't see me very well in this picture, but you want to stand up and you want to squeeze in or pull up at your navel, because your muscle goes like this, and the urethra, gotta make sure I said the right one, urethra goes through that muscle. So the muscle goes from the umbilicus to the rectum. Okay, so you want to pull up at your abdomen and squeeze at your buttocks and hold that for 10 seconds and breathe. So pull up at your navel, squeeze at your anus, and hold it. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. That's one. That's a good Kegel, that pulling, that strengthening of the muscle. How many of those should people do a day? 100. That's what the incontinence nurse said, 100 a day. So she would suggest that people would take, you know how if you have a garage sale and you put those little dot stickers on? She said you should put a little red dots around your house, and every time you see a red dot, you should do some Kegels. Oh, I tried to do that one time. I just thought, oh, let's just see how realistic this is. Well, it's not realistic. I tried. 100 a day is a lot. So nevertheless, you want to do it. They've come up with a lot of different things to help strengthen that pelvic floor. There's that muscle, there's those exercises. They even have for women a vaginal insert that you, I'm serious, when I heard about this, I went, this is crazy, but it's actually synced to your computer so that as you're doing your Kegels and squeezing, it can sense the strength of the contraction and it registers on the computer. You can play games with it, like Knockout Stars. Okay, I'm not making this stuff up. It is true. Here's the thing we need to know about incontinence. It can be reversed in many cases. The incontinence nurse said that she could resolve like 90% of most cases that came to her, because it has to do, there's just so many things. There's mechanical means, there's physical means, there's behavioral means like the strengthening exercises. So there, surgical interventions, meshes, medications, let's not forget those, that can help as far as incontinence and training. There's bladder retraining, when people need to retrain their bladders. If someone's had a urinary catheter for a while, we may need to retrain their bladder because the bladder just kind of atrophies. And so how do you build that tone back up? And so we might clamp the catheter tubing so that urine will stay in, and then they start to feel uncomfortable, and we empty it and we see how much they can tolerate to start building some tone. Sometimes people have to self-catheterize. I took care of a paraplegic, and she didn't have bladder control, and she catheterized herself all day long. Every 4 hours or so, cath herself and get rid of the bladder, or get rid of the urine. They're a higher risk for urinary tract infection, and so it's important that we teach them good technique for doing, getting their urine out. Maintenance of skin integrity, IAD, right? Can you remember what it is? I remember. Incontinence associated dermatitis, and so protecting skin, and then keeping people comfortable, and providing privacy to go to the bathroom. Most people don't like people staring at them, like putting them in the bedpan. Are you done yet? But I've had patients, I'll put them on the bedpan and I say, I'll be right back, and they'll go, I'm done. Good, okay, that'll work. Work with your patients. It's individual, that's for sure. All right, well, that's a good lot of stuff. So let's do just a couple questions, and here we go. Which of the following is the most accurate measurement of glomerular filtration? You should know this. Blood pressure, INO, creatinine clearance, BUN. Creatinine clearance, remember it's that commensurate measure. Whatever the creatinine, urine creatinine clearance is, it's a measure of what the glomerular filtration rate is. And so they go together. Here's a fun one. List the steps of collecting urine from an indwelling catheter in the correct order. So look at those. You can pause before I give you the answer. And here you go. So you want to clean the collection port. You want to withdraw the 10 milliliters of urine with a needle or the adaptive device. I need to update my slide. Inject the urine into the container and then label the container with the name. I got this from a NCLEX prep book and I missed it. Why? Because I would label the container first. Because that's what I would do. And that's what you see done a lot in doctor's offices if you have more people are going in and out of the room and they have their cups there, and so that you want it labeled. And consequently, because of that, I don't put it on a test because I don't think it tests well. But the key here, the discussion point, is the container does need to be labeled with the name, ID, and such for collection. So if you wanted to label your container first, you too could have it correct. All right, that's what we have for urination. I just want to mention that I did post a urinary elimination crossword puzzle, and so that's kind of fun to do. And then there's a critical thinking activity, and I want you to do that. It's related to the care of a client with a UTI, and there are a couple questions beyond what we discussed here that we can look at after you do your homework. And so turn your homework in online. I set up an assignment for you, assignment link, just like you're doing now in skills. So submit that to me, and I don't care in what form it's in particularly. I'm just going to check it off that you did the work. So you can do it in a document format or take a picture or PDF or whatever, but I just need you to upload it online so I can check off your homework this time, and then I'll post the answers the day after or later that day of when you turned it in. All right, well, have a good week. Hang in there, guys. Couple more recordings, you're gonna get this. All right, we're doing it. All right, talk to you later.